Shall we start?
Yes.
Okay. Good afternoon, dear colleagues, dear friends. I have a great pleasure to welcome you to the Beale lecture that is awarded by the Operational Research Society every year. It is held to honor the legacy of Martin Beale. Just a few words about Martin Beale. He graduated from Cambridge University with first-class honors in mathematics back in 1949. Martin Beale was a pioneer in mathematical programming, which he used to solve complex industrial problems. Today we will have two talks, one given by Dr. Elizabeth Williams, who is our doctoral award winner, and after that talk given by Professor Sally Brailsford, who was awarded the Beale Medal. Our acting executive director, Gavin Blackett, whom I am sure majority of you know, will handle the questions you may have online, but there is also opportunity to have questions in person that will be also answered. Our first talk will be given by Dr. Elizabeth Williams, who got a doctoral award for her PhD thesis entitled Linking Predictive and Prescriptive Analytics for Modeling Healthcare Services for Frail and Elderly Patients. Elizabeth is a postdoctoral research associate in the School of Mathematics at Cardiff University, specializing in operational research with a focus on healthcare systems. Elizabeth was awarded her PhD in mathematics and operational research from Cardiff University in 2023. She is also a member of Cardiff and Wales Health Board, that is equivalent to NHS Trust. She is working mostly on projects on hospital bed management, staffing optimization, and system resilience. Elizabeth, the floor and the Zoom is yours.
Thank you. So hopefully you can see my screen okay. So I'm Elizabeth Williams, Sanya kindly introduced, and I'm a research associate at the School of Mathematics in Cardiff University. So I'm going to talk about my PhD research, which was supervised by Professors Daniel Gartner and Paul Harper. And again, I did my PhD at Cardiff as well. So my PhD was funded by the Aneurin Bevan University Health Board, which is similar to an NHS trust in England, and as well as the European Social Fund and KES2 East. And the title of my research was Linking Predictive and Prescriptive Analytics for Modeling Healthcare Services for Frail and Elderly Patients. So firstly, I'm going to talk a bit about the motivation. So the UK is just one of many countries which is facing the challenges of an aging population, and it's continuing to grow at a kind of unprecedented rate. So elderly and frail patients often require more direct nursing care. They have more complex needs and they experience longer recovery times in hospital. So traditionally, these patients can be often included within the general adult population when looking at modelling, but the issue is they have longer recovery times in hospital, so they should be considered separately. So from this bottom graph, you can see that the darker the blue shows a higher proportion of those who are aged 65 and over. So this is somewhere that, as you can see, the whole of the UK will be facing in years to come. So I started my research by looking into the literature as to what had already been done in kind of frail and elderly patient care planning. And what we found was there was a need for integrated models that cover multiple care settings. So a lot of research tends to focus on one single hospital ward rather than focusing on a whole hospital or multiple hospitals. So this is something we wanted to look into. More research should assess how kind of models improve patient outcomes and quality of care. And finally, we found that there should be a larger variety in OR or management science methods, beyond just simple Markov models and simulations, as that is what currently is tending to fill the literature. So a bit about the health board itself. So it's located in southeast of Wales, and 20% of the residents are aged 65 and over. And the Welsh Government expects this to increase by 16% in the next 5 years. And as you can see, this is obviously a big issue. And when we break it down further, 15% are actually aged 75 and over, and the Welsh Government expect this to increase by 24% by the next 5 years. And then finally, 10% of over 65s in the UK live with frailty, and this rises to between 25 and 50% for those who are aged over 85. So this is a big issue. It's not going away, and not much research has really been done into these kind of patient management. So a bit about the data we had. So one of the great things about this project is because we were working in collaboration with one of the health boards, we were able to kind of get the data we were wanting to look into. So we had data which covered 3 years, and it was all pre-COVID data. And this equated to around 165,000 patient records of patients who are aged 65 and over. We used this kind of age group as our definition and under kind of bracket, as this is what was traditionally used in the literature. We also used frailty as someone's hospital admission code relates to a frailty syndrome. We found that actually there are multiple different ways of measuring frailty in the UK, so we tried using this one as this is what was recorded. We had 14 different hospital or care settings, and there were a variety of different attributes in the data, for example, age, date and time of admission and discharge, the hospital they were admitted to, which specialty, and whether they had any specific scan details. So one of the first things we did was looking at predicting length of stay for elderly and frail patients based on their admission characteristics. And we used an algorithm called CART. And what this does is it is used to group similar attributes together to predict an outcome variable. So we used 10 variables, which came from our base data. So these were kind of the attributes patients came in with. So this could be the age, the hospital they were admitted to, and which specialty. We used an 80% train set and a 20% test set, and we looked at both regression and classification, so predicting continuous and grouped length of stay, and we did some parameter hypertuning to work out the best combination for kind of our samples, so there were some differences between these. The main reason for using CART was it enabled a visual tree to be shown to practitioners. So someone who may not have a maths background would be able to understand the logic behind it and be able to see kind of the visualization. So what we found was that the admission method is the most important factor in determining a patient's length of stay. So as I mentioned, the model was run with grouped and continuous length of stays, and our continuous length of stay accuracy was only around 35%. But this was because our range of length of stay was between 0 and 417 days with a maximum number of 30 leaf nodes. So this was quite difficult. However, this was still an improvement on linear regression, which shows the benefit of using these kind of algorithms. And then we also did grouped length of stay into less than 1 day and greater than 1 day. This was guided by the health board because they were interested in seeing those who should be admitted and discharged on the same day and those who weren't. So on the right-hand side is a very simple kind of example branch. So it shows that the admission method, if you were the elective waiting list, and you were admitted to the specialty of trauma and orthopedics, it was down to which hospital you were admitted to as to whether you were expected to have an overnight stay or if you were discharged on the same day. So what we were able to do is take these 30 leaf nodes at the end containing these patients' information and push this into a 2-stage stochastic model. And this would be able to determine bed and staffing requirements across the Aneurin Bevan University Health Board. So 2-stage stochastic modelling, what is this? So in the first stage, we make a decision and we don't know what is going to happen in the future. And in the second stage, we see a realisation of the stochastic elements of the problem. However, we can make some changes and further decisions to avoid the constraints of a problem being infeasible. So in other words, in the second stage, we have recourse to a further degree of flexibility to preserve feasibility, but this comes at an additional cost. So more formally, this can be written like this. So if we break this down, the first stage problem, which is in the first line equation 1, is the aim to minimize the objective function g of x, which is equal to f of x plus e of psi q x psi. And so here, x is the first stage decision variable, representing the choices we make before uncertainty of psi is revealed. The function f of x represents the direct cost of this decision. And e of psi q x of psi accounts for the expected cost of the second stage problem. So then once psi is realized, so our uncertainty, we can then formulate our second stage, which is given in equation 2. So here, y is the second stage decision variable, representing the recourse action taken after the uncertainty is known. The equality constraint ensures that the first stage decision x and the second stage decision y together satisfy any constraints imposed by the data. So now moving on to kind of the parameters and decision variables. So in our model, we had sets of all hospitals, sets of all specialties. So for example, if you had a heart problem, you would be admitted to a cardiology ward. We had a set of nursing bands. We had a set of regions where our hospitals were contained. And then for our scenarios, we had a set which contained different things. So for example, if we wanted to increase demand, reduce demand, what the effect would be. So then we had different parameters. So the first 4 here relate to different costing. So for example, if we were to have a cost of deploying a bed today, if we decided in the future we may need additional beds, these may come with additional costs. So for example, if you need to open up new wards, if you need to take beds from other specialties, it's trying to factor in these costs. Then we had the cost of nursing staff. So if we were to deploy one today, and then if we were to deploy one in the future, we might need to rely on agency or bank staff, and these again come with additional costs. We also have the probability of different scenarios happening. And then we have our demand matrix for each specialty for patients arriving from each region, and we made this scenario dependent. We also had a ratio of nursing staff to patients for each specialty. This was because there are guidelines by the NHS as to how many patients or how many nurses should be to each patient. And then finally, we had the number of beds available to open in each specialty. And so then we had some more parameters, and these were kind of the upper bounds. So these were kind of physical constraints we couldn't exceed. So for example, we can't deploy more beds in a hospital than there are physically. We were assuming that you couldn't put patients in corridors or on chairs waiting for a bed. And also we had a limited number of staff, and we couldn't exceed this. So then we have our decision variables. So this is what we want to work out. So we want to know how many beds we should deploy in the first stage, and then how many staff we should deploy in the first stage. And then secondly, how many beds should we plan for the second stage, and how many staff should we plan for the second stage. So now we have our objective function. So this is split into 2 lines here. So the first line represents our first stage, and the second line represents our second stage. So our overall aim is to minimize the total costs of bed and staff across all hospitals. So the first line is the first stage. So it is the number of beds times the cost, as well as the number of nursing staff times the cost for nursing staff. And then similarly for the second stage, but times by this probability of each scenario happening. So then we have a list of all our constraints, and I won't go into these in detail, but the idea is that you can't exceed kind of capacity of the hospital or the staff. You have to meet your demand, and we have to make sure that our staff to patient ratios are met to meet with the NHS guidelines. So in order to do this model, we developed it in both Microsoft Excel OpenSolver and Python using the pulp package. There was reasons for using both. So the NHS are typically more familiar with using Excel. So we wanted to make sure that the model and the overall product would be accessible to them. And additionally, the benefits of using Python was that it was a bit faster, and it produced some nice visuals as well. So it was nice to have both kind of options, and it also validated each model. So for our costings, we used open access or data from NHS Scotland, and we used the 30 leaf nodes to develop a demand matrix. So talking about some of the numbers we used, we found that we had 14 hospitals in our health board, and this belonged to 6 regions. So we also had 29 specialties. And as you can see, if we've already got 14 hospitals and 29 specialties, this is quite difficult for someone to work out by hand where they should deploy beds. So we used 3 nursing bands. And in this scenario that I'm talking about today, we used 4 different scenarios. So there are a number of different ways we could generate demand. So typically in the NHS, they plan on averages. So we wanted to do something similar to that. We also then went further and did some more tailored examples. But today I'm just going to talk about the average daily demand formula. So what we did is take the number of patients for each node or leaf of a tree, and then times by the node average length of stay, and then divide this by the total number of days in the data. So for example, if we take Neville Hall Hospital and for the specialty of care of the elderly, we had around 2,700 patients, and we found that the average length of stay these patients take for this node was 11.4 days, and this ended up with a daily demand of 28 beds. So we did this for every node in which covers every hospital and every specialty. And what we end up is a really big kind of demand matrix. So what we decided is that hospitals should be grouped into their regions. So patients be divided into each kind of hospital based on their region and where they come from. So we have our 6 regions and our 29 different specialties. Now, as you can see, there are some very small numbers on this, and this is kind of to show that actually some services aren't in demand all the time. But typically, on average, we need around 950 beds available per day. So this is the deterministic implementation. So this is our first stage kind of model without looking at any stochasticness. And by using Python, we ended up with this visual here to show for each hospital and each specialty how many beds should be deployed and where. So what we found was we had a cost of around £990,000, and this was deploying 997 beds and 606 nursing staff. So again, the visualization shows where exactly these patients are deployed or these beds are deployed to. So then what we were able to do is then look at some stochastic scenarios. So here is a very simple one. If our demand was to increase by 5%, 10%, and then to decrease by 5% and 10%, all with equal probabilities, what would this result be? So again, we have a nice kind of visual showing where beds are deployed, and our cost is slightly more, but this would be expected. So as we can see, we're deploying slightly fewer beds in the first stage and then more beds in this second stage. And again, similarly with nursing staff. One of the good things about this is we can then work out how successful this model has been, because obviously the stochastic model will always be more expensive than the deterministic. But what we can do is we can calculate something called the value of the stochastic solution. And what this means is you take the deterministic model and fix this as the first stage in the stochastic model. And what it's kind of showing is how well, if you were to run with the deterministic model, how well would it perform in a real life kind of stochastic environment? So as you can see here with this test row, our X bed and our X staff remain the same as the deterministic. And then the stochasticness happens and we can see how many additional bed and staff we require. And actually, if you look at the cost saving between the stochastic and the test, it shows that by planning originally on the stochastic model, you end up saving £26,500 per day, which is approximately 2.6%. Now, 2.6% doesn't sound particularly high. However, within the NHS, when we're talking about millions of pounds, this is actually a really big saving, and there's value in being able to distribute this money somewhere else. So this shows that really you should be planning with stochastic models rather than traditional deterministic models. So what the great thing about this is we could go to the health board and say, well, what would you like us to look at? And we could run scenario analysis on specific leaf nodes. So we could say, well, what if this leaf node was to decrease by this amount? What if this other node was to increase by a certain amount? And we can play around and tailor this to kind of what the NHS would like. So in this example here, we increased the same node by 20% and left the remaining 29 nodes the same. And what we found was that actually our saving increases, and we had a cost saving around 2.8%, again showing the benefit of using the kind of the stochastic model in the first place. So kind of what we found was that the CART kind of algorithm was improving accuracy compared to linear and logistic regression models and determined patient clusters of similar attributes. Kind of the visualization was really beneficial because it meant someone without any mathematical knowledge could understand and follow this kind of tree diagram. We found that using two-stage stochastic optimization models over traditional deterministic models can provide large savings for the NHS. And we found that linking predictive and prescriptive paradigms can allow for specific scenario testing to take place, and we could tailor these needs to the Nairn-Bevan Health Board. And within my thesis, we also extended these models to include the M penalty method, long-term demand predictions, and within kind of the timeframe of my PhD, a new hospital opened, so we're able to include that within the planning as well. This work is currently under review, but it is available on archive. Yes. So where is this kind of work going? Although my PhD is finished, led by Professor Daniel Gartner, we were awarded LEAP funding for 2025. And this is looking at planning and resource integration in digital environments and the case for frail elderly patients and palliative care. So hopefully this work can go on and support this. So the idea of this project is to optimize resource planning for frail and elderly and palliative care patients using predictive analytics and digital health solutions. We can enhance personalized care, reducing hospital strain through data-driven decision-making and improved service integration. And then we really want to improve patient outcomes. And this is kind of ensuring the right care is delivered in the right place at the right time. And we had our kickoff meeting this morning, which went really well. So we're looking forward to where this kind of work is going to take us. So that's all I have to say for now, but thank you very much for listening. And I'm very happy to answer any questions if there are any.
Thanks very much, Elizabeth. Excellent run through that. Very difficult to summarize 3 or 4 years work in 20 minutes, I'm sure. We've got a couple of questions that have come through so far, so let me relay those to you. What percentage of beds are used by the patients that are 65 and over?
Off the top of my head, I'm not quite sure because the only data set we had was those who are over 65. But I think what they ends up happening is even if it's not like a right percentage split, they're staying longer. So what you'll find is actually they do end up staying quite a bit more time in hospital. So they end up taking a higher proportion of the percentage split compared to the under 65s. But I don't know the ratio off the top of my head, I'm afraid.
Okay, thank you. Next one from Ruth. Easy for Ruth to say. This all looks great and seems very straightforward. What were the most challenging things about planning the work and getting the modelling to work and be useful?
Yes, so I guess probably the most challenging thing is I started my PhD and then COVID happened. So the priorities of the health board changed, and I guess, you know, where they wanted to take this work maybe had to change because of COVID. I guess probably the biggest challenge is the data, because it's never as nice and as clean as you want it to. And again, trying to make it so the model was useful. So the model has been used and is being used, I believe, by the health board to help with their kind of planning cases. But again, it's still working in collaboration kind of with the health board to kind of to try and implement this into the system. Again, it's why we decided to do both an Excel model and a Python model. So there was that flexibility as to which model you wanted to use, as to kind of where they were trained in order to help them. So I hope that answers your question.
Thank you. So following on from that one from Janet Williams. So she's asking what the reaction of the health board has been to this modelling work, and are they starting to use what the modelling is saying for their planning?
Yes, so I think again, it's a kind of a working involvement and working collaboration. So they're trying to use it kind of further up in their kind of planning team within ABCI, which is a specialist kind of part of the health board, where one of my supervisors, Daniel Gartner, works. I think they really like the deterministic side of the model because it's what they're familiar with, and they're still trying to get to grips with the kind of stochastic side and how to kind of really benefit from kind of that area. So hopefully it will be kind of implemented and used to make decisions down the line. As with the NHS, I think things just take a bit of time kind of to get moving and to get accepted. But yes, hopefully in the future it will be used.
Okay, we've got a couple more through the Q&A, but let me first ask Sanya, our president. She's got a hand up. She's probably the only one who's allowed to do that on this meeting, but never mind.
Thank you very much. Just it's easier than to type. Elizabeth, you mentioned you have data from a number of hospitals. Did you consider them separately, or did you make a big, what is usually called data warehouse? And the reason why I ask that is, are these data from different hospitals standardized? What time you spent cleaning the data?
Yes, so I guess the data is all stored in one system for this kind of health board. So we considered each hospital separately, and this was because different specialties don't necessarily operate in every hospital, so we couldn't account for all 29 specialties across all 14. So yes, we had to clean them or account for them separately, but then we did group them up into regions. So it meant that patients ideally wouldn't be going too far away from home, and they'd be staying in that same region if they could get that care. But yes, in terms of where the data is stored, it's all stored centrally. So we didn't need to go to each hospital to collect data. It was all kind of available as one.
Well done to NHS Wales then.
Sure.
But then
I can't take the
your
credit.
algorithms were general enough to handle different maybe attributes even.
Yes, so the idea was that this could be taken and applied to any kind of health board or NHS trust, and it was kind of universal that if you wanted to apply it to a specific kind of age group, so pediatrics or young adults, you could do that. You could apply it to certain specialties, so you could just look at considering a cardiology department and where to deploy beds that way. Yes.
Thank you.
Great. Just so back to the Q&A stuff. I think that will have answered Robert's question about whether the problem can be decomposed into different regions. So that's okay. We've got an answer from the floor on one of the early questions. And let me just read that out. In response to a previous query, in the 1990s, the proportion of hospital inpatients over 65 was approximately 2/3. and the anonymous attendee is sure that this proportion will have risen significantly since then. Okay, back to the actual questions. One from Lucy Morgan, who's now working in the NHS. Great talk, Elizabeth. Could this model be linked to external community care? There seems to be bottlenecks in getting people out of hospital once treated, especially for the elderly. Was that a consideration?
So at the very start of my PhD, we did think about trying to consider community care into kind of our model. However, it was just too difficult to kind of get data. And again, because COVID happened, it meant that trying to get this data was more difficult. But again, it could be applied into kind of nursing kind of care as well. Sorry, community care to like plan kind of beds and trying to work out how to reduce kind of bottlenecks within hospital beds, because that is caused by lack of beds within the community. So I can't see why there shouldn't be any reason it couldn't be expanded into community.
Okay, and this one from Michael Ambrose. He says, probably an ignorant question as he's not a specialist, but how do you evaluate risk on the output being wrong? For example, it predicts X beds and Y nurses, but do you consider a buffer for risk?
So we didn't, but that again could be added in if you wanted a, say, 5% threshold, you could add that as part of the kind of algorithm on top. I guess part of the reason we didn't is because at the moment they don't really have a buffer. It's all worked out kind of manually by kind of hospital specialists on the ward saying this is how many beds we think we need. But again, the idea is the model can be adapted and developed, so you could add this buffer or kind of standard deviation on if you wanted to.
Good. And one from me, again, I'm going to use the ignorance card too. Could you use this model to go back to look at the actual planning from the period the data covers to see how well it was done at the time, or whether there were savings that could have been made?
So again, yes, you could have and looked at, say, for example, kind of fixing what the planned beds were in our first stage and then using the actual for the second stage and seeing where the discrepancies were and how much additional kind of funds were spent because you didn't have this demand in the first, the bed capacities in the first place. So that would be really interesting to go back and look as like a, how successful did they do or how not successful were they? So yes, it could definitely be used for that.
And again, would there be any sort of rules of thumb emerging from this that the specialists who are doing the planning could pick up and change immediately how they're doing?
I think potentially, yes, if there was something that they were always missing, for example, 10% of beds, then this is something that they should be looking more into and they should plan accordingly. Again, the nice thing is a lot of the time in the health board, you need evidence to show that you can spend more money or you can have more beds. And this is a nice visual way where they can actually say, look, this is what we're doing. This is the expense we're having. So this is kind of a nice tool that they can use for that.
Right, next one. How is quality assurance carried out against models developed within the research sector?
So a lot of it comes down to validation and verification. So by working kind of closely with the health board, we had some input from them into kind of the results they were expecting. So in terms of bed numbers, you can see, I think there was NHS Wales shows how many typically beds they have available per day online. So we were able to see that and compare what our results were and see how different it was. Obviously, I can't talk about the whole research sector, but I think that in general that there does go on a lot of kind of validation before kind of these models are kind of inputted, especially into the NHS. Yes, so hopefully that answers that.
Yeah, great. And perhaps a more general one from Miguel. What advice would you have for a starting PhD student in a project like this involving the NHS? What do you wish you knew?
I think there'd be a couple of things. So I think firstly, to understand kind of the NHS data and kind of the background, and there's lots of kind of specialty like nuances and terms, so trying to get your head around that kind of early on is really important. I would also say kind of if you have like an NHS partner, it's really good to be involved and have meetings and try and speak to as many different people that you can. Because there are lots of people who've worked in the NHS for many years who have so much experience and knowledge, and that's kind of a fountain that you want to kind of take from and use. So yeah, I think trying to get involved within kind of the area is a really important thing and a key to success, really.
Great, thank you. Go back to Q&A. I think that's covered everything that we've had so far. Last chance for any more, if anyone wants to add anything.
Any in the room here? Any questions?
Yeah, Mark? So we're going to try with the owl thing. If the audience online can't hear, give us a shout and Mark.
We can hear you very clearly, Sally.
Yes, that's because I'm really close to the mic. No. Do you want to just come and stand up?
Oh, we can. Let's see whether we can switch the microphone.
Oh, I thought I'd put it on. Right. Try again.
Can you hear me, Gavin?
I can hear you, Mark. Yeah.
Right. Okay.
Right.
I'm standing. So Elizabeth, thanks very much. Really interesting talk. My question is, I understand why the 65-year-olds are over 65s are important, and I've got a vested interest.
Yeah, very important.
But I don't understand how you can consider them in isolation, because they use the same beds and the same staff as everybody else.
So I agree, yes. But I guess typically because they're just, when bed planning happens, they tend to be included as with the under 65s. So it'd be, they plan for a cardiology ward, how many beds do we need? And then again, averaging how long on average people stay. So they're not taking into this kind of subset of patients into kind of consideration. And because they're staying longer, it's what's ending up happening is you're not having enough beds. So the idea is you could take this model and say, we're going to look at all our different patient subgroups and then plan on a wider scale how many you need. The health board roughly know for over 65s how many they need. But again, that's more by kind of guess of thumb rather than actually kind of calculating it in a mathematical way. So I agree that you need to also consider the others, because obviously you're limited by what your maximum hospital capacities are. But these patients need to be considered as a separate cohort rather than just in the general adult population.
Right. Thank you.
Thank you.
Anybody else from the room? Okay, am I allowed to ask a question? So first of all, well done, Lizzie. That was a great talk and congratulations on your award. I mean, I just kind of slightly following on from that last question, and also the one about social care. I mean, a lot of these people's length of stay, a large fraction of that length of stay won't be because they need to be in hospital, but just because they couldn't discharge them. I mean, is it possible to account for that in the model in any way? And I guess you don't know.
So I guess, yes, thank you for your question. So again, obviously we're using kind of retrospective data, so we're only looking at what has happened. And yes, bed blocking is often caused because these patients can't get out into the community, whether that be there's not enough nursing home beds or they're waiting for funds to clear. So it is a big issue. In terms of trying to plan for that, if they know that, okay, in the future, they know they can clear up a third of bed days, or they can reduce someone's length of stay by a certain amount because they know they will have the capacity. They can then model for that accordingly. But obviously at the moment, as you've probably seen in the news, this issue, it hasn't really improved. So it's important to account for this bed blocking because it's still there and it is still happening.
I think that's all from our end. So.
Can I ask another related one then? If the health board want to make adjustments or additional functionality within the model, are they starting to get that capacity internally, or do they have to come back to you?
So as part of the health board, they have something called the it's ABCI, which is the United Bevan Continuous Improvement Team, and they work doing kind of modelling within the NHS. So they have previously all done PhDs in mathematics, so they have the experience there to be able to go and adjust kind of things, and then they can go and deliver and teach this to potential staff within the NHS. And teach them how to have these kind of capabilities. So in theory, they could come back to me and ask, how do we do this? But they're a lot more knowledgeable and experienced. So I suspect they would be able to go and adjust things slightly for themselves. But yes.
Great, thank you very much. Okay, let me just check Q&A, nothing more in there. Nothing more from the room. In that case, I'd like to thank you, Elizabeth, for an excellent talk, great answers to the questions.
Thank you.
Congratulations on your award, and looking forward to hearing more about your work as it progresses.
Thank you very much.
I'll hand back to Sanya, who I think is going to introduce to this other person. I'm not quite sure who she is. Sally, somebody?
Is it possible that we could have a 2-minute break? Because we've got pastries and coffee and tea in our room.
Oh, showing off now.
It just might give people a chance to go and fill up before.
Great. Thank you. Okay, so I'll hand back to Sanya for her introduction.
Thank you, Gavin. So we are staying in healthcare, and our next speaker is Professor Sally Brailsford, who was awarded the Beale Medal in 2024. I believe that the majority of our audience knows Sally very well and her contributions, especially in healthcare. But I will just say a few words about Sally. Sally is Professor of Management Science at the University of Southampton, where she has spent the majority of her academic career. She is well known for applying operational research to a variety of healthcare problems, such as optimization of emergency healthcare, improving cost-effective screening, then dental workforce planning, to mention just a few. More recently, Sally has carried out research in hybrid simulation and monitoring of human behavior in healthcare systems. Sally was the vice president of Operational Research Society and also of Euro. She was also a coordinator of the Euro Working Group on Operational Research Applied to Health Services, known as ORACS. And Sally was a founding editor-in-chief of our journal of the Operational Research Society Health Systems. Her research was mostly supported by EPSRC and NIHR. Sally, please, we are looking forward to hearing your talk.
Thank you very much, Sanya. Let me just share my screen. There we go. And let me just get rid of all this lot. Okay. So first of all, thank you very much, everybody in the room, for coming. It's just lovely to see so many people, old friends, new friends. Let me get this slide working. There we go. I just wanted to give you a slightly different idea about my career. And the reason why I called it a half-life was because basically half of my life, I didn't know anything about OR. I only discovered it at the age of 36. And you can then work out how old I am, which is actually not quite true. I'm actually one more year older than that. But I think, like a lot of us who come to OR, started out doing a degree in mathematics, I had no idea what to do with it. I'd worked as a nurse as a student, so I ended up nursing. But prior to that, I also worked for the BBC, and not many people know that. And this was only clerical work. I was looking after the mailing list for the equivalent of the Radio Times for the World Service, which was called London Calling. I then had 3 kids, decided I didn't want to go back into nursing, basically ended up at Southampton doing a master's, which I thought was going to lead me to a career in the NHS, doing some kind of analytics or whatever it was called then. But in fact, my master's turned into a PhD, and I've not been able to get away since. So I'm going to be talking a little bit about OR and healthcare, but I'm going to be focusing on one of my obsessions, which is getting models used in the NHS and not just published in journals. I'm going to talk a bit about something that I've been thinking about a bit recently, which is about model size and the concepts of whether size and simplicity, how they're related, and also accuracy and usefulness. Give you some examples of some stupidly big models. Then I'm going to go on to talk about digital twins, which are the kind of latest buzzword, and say finish up with some lessons learned. And I'm going to be talking about quite a few people, some of whom are in this room and some of whom I think are online during the talk. So OR in healthcare, as I said, it's a great area to have been in. It's got a huge literature, and there's not just OR modelling done by academics, it's also done within the public sector groups like Gauze and also the business consultancies, and in particular simulation, which is what I do. But the question I was asking is, has all this modelling been successful in the sense that the operation, if you like, was all our models, but has the NHS in particular actually benefited from all these models? Has it improved? So it kind of depends how you define success. So I go to 2 of my simulation heroes, Stuart Robinson and Mike Pidd, who published this study back in 1998 about perceptions of success. So they interviewed 20 simulation modelers basically and asked how they defined success and did they, how it was perceived at different stages. And so in terms of us as academics, basically it's very rare to find in a journal article people reporting that a model has actually been implemented in practice, let alone that as a result of that implementation, there's been some kind of benefit achieved. If you're a business consultant, of course, that's what you really want to do because you want all these client testimonials about how fantastic your models are. But us academics tend not to actually even get as far as stage 2 sometimes. So if you're being a slightly more cynical take on this, there's just 2 things. First of all, the model has to be correct, so it has to be peer reviewed, and then it has to be published in a good journal. If you're in a business school like me, it has to be published in an ABS 4-star journal. And in order for that to happen, it's got to contain sort of some novelty, innovation, which generally means it's really complicated and nobody can understand it. So it does help a little bit if you're using real data from a hospital or some kind of healthcare organization. Quite often you'll read papers that say that, this model was developed in collaboration with Hospital X. And in practice, that can mean anything from they gave us a bit of data right through to we worked closely with them throughout the project. So I think in terms of that cynical definition, there's no doubt that the surgery was successful. So there's a huge literature, both in general OR journals and specialist ones. There's lots of special issues, healthcare tracks at conferences, specialist healthcare conferences, including my favorite one, which is 4 hours. But I have to say that in many cases, the actual healthcare aspects are not the main thrust of the paper. And this is because some academics, of which I don't think I'm one, like to be able to test out their new algorithm or idea, whatever it is, on some real data, but they really don't want to do the messy business of actually going out and talking to people or having to get up at 7 o'clock to meet doctors, whatever, let alone having to make it user-friendly and then provide technical support indefinitely after that. We're not paid to do that. We're paid to do the research and then move on. So I think with a lot of this literature, the actual healthcare aspects are not the main thing. And for sure, the patient is just getting worse. I mean, these are just a few random samples. I did particularly pick out a Welsh one because I thought Lizzie might be listening, but it doesn't matter where you are. You know, we all know that the NHS is in a mess. And the problem is that even going right back to the 70s, all the literature views say, yeah, there's huge literature, but nobody is actually using these models. And a whole load of reasons are cited, which obviously data is one of them, but there are a whole load of other things. And until impact became part of the ref, there was no incentive for academics to follow up after a project finished. We were then on to the next one, write the next paper. NHS managers didn't always appreciate what OR models could do. And NHS analysts didn't have the skills other than Excel to actually use models, or let alone be able to afford the software. So that's a slight exaggeration, but not too much of an exaggeration. There are some pockets of success, I mean, of which I think obviously there are models which are used in terms of policy making. We all know about the COVID models, which sadly were not developed by OR people. And one of my annoyances is the fact, the extent to which OR was not really used for where it could have been used for informing operational decisions, things that we know it's really good at. And also things like NICE, which I see Keith sitting there, I know he's worked for NICE and built some models which look at to see whether it is cost effective for the NHS to allow a new drug to be made available to the NHS. And there are some small groups like Paul Harper's group. We've had an example of the sort of work they do there. But and of course, there's loads of models developed by consultants, which may be fairly simple. They might be quite complex. Who knows? We don't really know because they're not published. I cynically suspect a lot of these models are implemented, or at least the findings are implemented, because the client, the hospital, has paid £500,000 for, I won't say who, a nameless consultancy firm to come in and build a model for them. And if they spent that much money on it, then they ought to implement the findings. It's not really clear whether that's a good thing or not. And there have been some projects, and I've been involved in some of them, that have purposely set out to address this issue of management awareness and analyst skills. So they're sort of looking at getting at the project from the top down and the bottom up to try and get sort of understanding of the potential of modelling embedded. So as I say, over the years, I've been involved in a lot of projects which have been about how to get models used. One of them, led by Terry, sitting over there, was perhaps the first one. I'm not going to say what they are. They've all got great acronyms. So first rule is get a great acronym. The second project, Stefan there, we worked on a project while he was at Imperial, which was part of HackerIt, which I can't remember what that stood for. But our bit was to do with understanding the way that people use models. And MashNet, of course, which many of you will have heard of, which was a group whose aim was to bring together academia, business consultants and healthcare practitioners. The Cumberland Initiative, which was a follow-on from Wright, and then a number of other projects specifically looking at particular bits of software. So I'm now going to very quickly whiz through, I think in 3 slides, my life in research. So the first one, I really want to introduce one of my all-time heroes. And I just checked, sadly, I don't think she's online, but if you are there, Ruth, you are one of my biggest heroes in simulation modelling. So this was basically the first project I did after my PhD, and all the work I did basically prior to 2000 was in DES. In the year 2000, I met David Lane. I don't think we'd met before, but our paths might have crossed. But there was this event held at Warwick called Never the Twain Shall Meet, which was bringing together the two simulation communities, which had never really kind of collaborated before. And I have to say, over the last 25 years, these two communities have become incredibly joined. And in fact, a couple of weeks ago, we had an event here, which was a meeting of the UK chapter of the SD Society, which was joint with the Operational Research Society SIG. So, as I say, in the first 10 years of this century, I was building SD models, though I was still doing a bit of DS as well. And then basically since 2010, mainly system dynamics and hybrid simulations. So a whole load of models in different things where either using tools which were designed for either DS or SD, like Simulation VentSim, or a tool which does all three, any logic. So there's a whole load of different models. So I'm going to tell you 3 success stories now. I had to scratch around to find them. So this was the success in the real life definition, not my cynical definition, in the real life definition of a model that's actually informed a real world decision. And so this was a project that was actually a piece of consultancy, but it was a research project, which involved a lot of health services researchers and other colleagues, but also building an SD model of the whole system of urgent and unscheduled care in Nottingham. So, as I say, I was doing the modelling, but there were other parts doing interviews and things. And one of the interesting things they discovered that, I mean, what had prompted this project was problems in A&E. You kind of sound vaguely familiar. Long waits in the emergency department. There's a lot of the older patients had actually been sent to the emergency department by their GP because they were waiting for some diagnostic test that they had to be admitted to have. And the waiting list was so long, the GP said, well, if you just show up at A&E, they'll have to admit you. And so what came from the model was that once these patients were admitted, it was really difficult then to actually discharge them early. And if you could keep them out of hospital in the first place, was a lot better in terms of bed occupancy and all the other metrics and things. And so what they actually decided to do in Nottingham was to build a building, an outpatient centre in the grounds of the hospital, which was specifically for these diagnostic cases. So why was that successful? I mean, I think it came from, as I say, it was consultancy essentially. It came from a real world problem dealing with winter pressures. It had a fantastic project leader that brought together all these. He was a GP who brought together all the other stakeholders and all the other care providers. They recognised it was a system problem. It was very kind of locally visible, but it was also nationally visible because of the waits in A&E, which were probably now, if we had waits like that, we'd think wonderful. They had the funding to implement what the model produced, and the paper was actually published, and it won the 2004 Goodeve Medal. And I'd actually dug out that picture of me and Val and Joe at the 2000 and whatever it was, 2005 Blackett lecture. But I think in addition to that model, there were other parts of the project, and I'm going to talk a little bit about that later on, that were actually perhaps more useful for the client than the model itself. So my second one was joint work with my former colleague Terry Williams and 2 master students. So this was actually a summer project for 2 students. So the students went to Children's Hospital Wisconsin in Milwaukee. And at the time, they were moving to a new building, and the problem was, how should they allocate these extra beds between these 3 different specialties? So they had medical, surgical, and cardiac. And of course, all the doctors and consultants in those specialties thought that theirs was the most important and they should have the most beds. And what the students did was build a fairly simple simulate model. And so it looked at different allocations of beds and also different rules. So if one area was full, how should they, which bed should take up the extra patient, the extra patient. So the kind of different overflow rules, if you like. And again, what the options that came up from the model, the hospital implemented. And as far as I know, it's still operating like that. So again, why was I think that was successful? Again, it came from a real world problem. And fortunately, Terry had a long-standing, because he'd supervised the client's DBA, he had this, there was a good sort of trust relationship between him and the client, who was he wasn't a doctor, but he was a sort of senior manager. He thought that modelling was really useful, which was brilliant. And we had fantastic engagement from the hospitals, lots of good data. I think one of the key things was that the students weren't seen as threatening. And I think if the hospital had decided, to bring in PwC or Deloitte or whoever, they might have got a different reaction from the doctors to these students who were going around asking questions, who were just basically able to ask all sorts of questions. So it was essentially a really difficult political decision, which in fact, the answer, they worked it out for themselves with the help of the model. But I've never been able to publish this. I mean, I know if I attempted to publish it, these are the sort of comments I would get. So although I talk about it a lot, it's one of my 3 success stories, you couldn't publish that really. My 3rd one has been published, and this was a PhD project with a student who was actually a qualified dentist. And they'd had this problem where it was basically a political argument between these 2 ministries, where the Ministry of Higher Education, which provided free education, even dentistry, which is like the most expensive course you can do, is free. But the Ministry of Health was not willing to create posts for all these doctors when they were qualified. So the situation was there were 250 of them, and they were doing all sorts of things, like serving in McDonald's or whatever. They weren't able to go into private practice because they were newly qualified, so they didn't have the reputation. So in fact, what they were given funding to go overseas to study some specialist subject in dentistry. What Dilip did was decide to do a PhD on actually solving this problem, which was, I think, quite remarkable of him. He had absolutely no background at all in modelling at all, but quite an amazing person. And so he built this large Vensim model that was looking at the sort of pathway, the career pathways of dentists, where they come from, and also what the future need for care would be in different scenarios. And he presented the model to these 2 ministries, and they worked out that actually this was a stupid situation, and they created 400 new posts. So this was one of my impact case studies, because it did actually have some impact. I mean, I think the simplest explanation for why it was successful was Dilip himself. He was amazing. Because he was a dentist, he could go around and collect data. While he was doing his PhD, there was still a war raging in the north, and so it wasn't safe to travel. So I think that's the only PhD I've ever supervised where there's been actually a war going on during the process of data collection. But because he'd been working as a junior civil servant, he had access to these ministers as well. So, I mean, I think it was similar to the Children's Hospital model, in that it was a tricky political decision where actually people had to just sit down and see for themselves that what the answer was, in effect. Again, this model was actually published, and this is us at the 2015 or 16, I think, Blackett lecture getting our. And I put this last point in because when I was training to be a nurse, there was no way I would ever have imagined that I would end up in Colombo addressing the annual conference of the Sri Lankan Dental Association. That was kind of not what I thought I'd be doing when I was emptying bedpans. So those are my 3 success stories. These are all my failures. So basically, loads of different models on all sorts of subjects. Don't worry about what they are. Basically, none of them have actually ever been implemented in practice. I mean, they've been published in journals, and some of them have even won prizes, but none of them, or maybe we'll say hardly any, I think pretty much 0 have been actually ever used, which I think is really sad. I mean, I did want to end on a slightly positive note. I mean, we as academics, we will always need to publish. I mean, it's just a fact of life that, you know, that's what we get promoted on, that's what we get appraised on. And also, you need people doing this, what I call blue skies research, because if you didn't do that, then nothing would ever happen, and we'd still be back in the 60s building our simple models. So, I mean, I think, although I don't like doing it myself, there is a place for people who do theoretical work and sit in their offices all day. But I think particularly in healthcare, there are so many interesting problems and complex problems that come from healthcare that they actually drive the sort of, you know, the existing methods that we have are not fit for purpose. So we actually need new approaches to tackle these problems. And of course, you know, I think for people like me, impact being in the ref was great because, well, I mean, I think for all of us in OR, because OR is basically about solving real world problems. So I think it's good that impact has become kind of a good thing, and also that it gets funded now, so that, you know, when you're writing a grant, you have to think about how you're going to collect evidence that demonstrates its impact and so on. And also, we teach students, and our students go out and get proper jobs in the real world, and they hopefully will then be able to kind of remember some of the stuff that we've taught them. And some of us, Jonathan and I, and others, I'm sure, actually teach medical students. So we're actually running, at the moment, we're running a course called Systems Thinking in Healthcare, where it's an option for third year medical students. And we're just basically introducing to them some of the fundamental ideas of systems thinking and modeling, so that hopefully when they become important consultants, 15 years time, they will know that actually there are these tools out there that can be helpful. So how am I doing? I'm going to speed up a little bit. So we all know these quotes, don't we? So when I'm teaching modeling, well, in particular to people who don't know about it, I talk about models as maps. And so you start off with the reason you're building a model is to solve some problem or to understand something better, whatever it is, but there's a purpose to the model. And I think this is the key thing, there's a purpose. And so if you wanted to find your way to our house, which some of you might recognize, if you're arriving by plane, like Val and Mark did you come back to Southampton? No, you didn't, okay. So you wouldn't have had this lovely view. But I think that the only purpose of that view is to spot our house when you're coming into land at Southampton. If you use the map view, that's a model. It's a simplified version of reality, but it's actually useful for finding a way from A to B. But street view is completely pointless, I think. And it was obviously dustbin day, which it actually is today. But although it's not the recycling day. Anyway, this is a question about how much detail you need at a model. So this is another of my former colleagues who also worked with one of my other former colleagues, Chris Chapman over there. But I think this is Steve's. I know you did a lot of work with Steve, didn't you, Chris, on this topic? But so this was his JAWS paper about constructive simplicity, which I think is a really useful idea that that simplicity has 2 aspects. First of all, that it's not, say, it doesn't consist of many parts, which is quite straightforward. And secondly, that it's easily understood. And I think that the idea of transparency is important when you're dealing with clients, but the idea of the actual constructive simplicity, the nature of the model, is actually more likely to be acceptable to a client than a model that is incredibly complicated and opaque. But of course, it's really difficult to actually find the sweet spot. between making a model very detailed, you know, how much detail do you need, basically? So obviously, you know, there's a trade-off there, which is quite tricky. So a lot of people have looked at these issues in terms, in particularly in terms of well, this is, I said this is a general model, and so so what Brooks and Tobias were looking at was how complexity compares with performance, which is, as I say, has a number of dimensions. It's accuracy, but it's more than that. It's, you know, is the model reusable? Does it contain errors, etc. But they think of complexity as basically how many components in it, which ones are related, and how precisely are they related. And so that kind of forms the definition of complexity. And they say that, and I think we would all probably agree with them, that there's a lot of models are more complicated than they need to be to solve a particular problem. And of course, they agree that actually finding the right level is difficult. And they say it's perhaps more of an art than a science. So, so a bit later on, 2016, Ahmed Shah and Omar tried to get people's different ideas of what size and complexity were. So they conducted these 20 interviews with practitioners. And basically, they couldn't come to a single definition. One of them was a consultant, and this made me smile. He said, you know, he measured size in dollars rather than other things like variables, etc. So I mean, they're kind of what we would expect, I think, in terms of size. In terms of complexity, one of the ideas is, you know, how many questions can the model answer? And I think the more questions you try to get a model to answer, the more complex and opaque it becomes. And whether that's a good thing or not, I'm not sure I would agree with. So in 2023, Stuart Robinson was still looking at this trade-off between complexity and accuracy in this time. So he'd published a paper in JAWS back in 2008, which said that basically there was a sort of upside down bathtub curve. So as the model became more complex, it got more accurate up to a point where it reached a sort of plateau, and then it stayed. The more complexity you added, it didn't really add much to the accuracy, but then it actually started tailing off again. So he actually tested this out in his more recent paper with 3 different models, and found that actually that curve is not always the case. In fact, you can get anything. You can sometimes get increasing accuracy as you get more complex. Sometimes you can get decreasing, and sometimes it's the same. And of course, size is not the same as complexity, because you can have very, very large but simple models. So if you have let's say this manufacturing system can be enormous, but if the actual routing of product through it is the same, then actually it's a really simple model. Whereas you can have a tiny model, tiny single server queuing model, but if each entity has a large number of attributes which all combine in a particularly complex way that you can't solve analytically to work out the processing time, then actually there's a whole load of complexity hidden in that, what on the face of it looks like a really simple model. And you can get simple models that generate complex behavior. So I'm sure you've all seen, you can Google them if you haven't, these boids, which are basically agents moving in a 2-dimensional space. And their movement is governed by these 3 very simple rules, that they have to be a certain distance apart, they have to be aligned in the same direction, and so on. But once you set them off, the agents move around their space, and it's supposed to explain the way that birds flock and fly. And we're all taught that small is beautiful. This is a picture of 2 of my heroes at the same time, having a nice time on the beach at Winter Simulation Conference. And Mike wrote this paper for Interfaces. It's a really great paper, where he's got 6 principles, and the first 3 are about size. So he says simple models, but complicated, think complicated, and start small and add. And again, I think this is something we would all teach our students. And avoid mega models. So if you can, have a number of small models than one great big model. And so he's not the only person that that said that complexity is bad. So this was a paper in JOS, again, quite an old one, about the whole ethos of what we should be doing in simulation is trying to reduce complexity rather than make things more complicated. So another of my heroes, Ray Paul, had a winter sim paper which was looking at the reasons why people build complex models, which were sort of two types. They were partly to show off, particularly to clients, but also journal editors. There's also a thing they call the include all syndrome, which I think we've all had, where, you know, you want to include everything, particularly, I think, working in healthcare, when you talk to clinicians and they say, well, you have to include this and this and this and this because we know these factors are important. And you say, well, yes, I know they might be clinically important, but are they actually important to the problem we're trying to solve? I think if you're less experienced, it can be tempting to include everything because your clients, your stakeholders tell you to. And of course, because software is so fantastic these days, you know, it's so tempting just to add stuff in because we can. But there's also the reasons that people make models too complex because they don't actually understand the system or the problem. And there's also the issue of scope creep. So you start with trying to solve a relatively straightforward question and the client says, well, could you do this? And you say, well, yes, I probably could. I'd have to add this and this and this to the model. And then, you know, it just goes like that. But of course, small models have a lot of advantages because they're quick to develop and test and everything. You've also got less invested in them. You haven't spent 3 years building them. You might have spent 3 hours. And so you can chuck it. If the model turns out to be wrong, you don't really care if you throw it away and start again. Whereas if you spent ages on it, you're very reluctant to do that. You'd rather try and modify it. But of course, if the model is you can go too much the other way. And again, this is the point that Steve Ward was making in his paper. If the model's too abstract, people might not kind of understand it. So I think given the time, I'm going to not go through these. I'm just going to give you my examples. So these are some examples of what I've called insanely large models. So people in defense will know that there are loads of these very large models for kind of wargaming, basically, or training. And this one, so it comes from the States, called JCATs, but we do have them in the UK as well, which incredibly detailed, enormous models. I mean, this one goes right back to the 70s, I think, when it was the version 1, but, you know, stupidly big, really. Then we come on to digital twins. This is NASA's one. I'm going to say a bit more about them later on in the context of health, but, you know, a model of the Earth, basically. This is my particular hate. These very, very large epidemic models. Don't get me started on these. I've purposely only kept in the US one because I thought there'd be nobody here that was involved in building it. You know, and this is the biggest one I could find. It's called Flamingo. It's basically a model of the universe, and the agents, or the entities, whatever you call them, are small galaxies. You know, you can't get much bigger than that, can you? So in total contrast to that, so I've called those insanely large. Then I come on to what I've called small but useful. And so these are an idea called archetypes in SD, which I think originally started with Peter Seng, and I'm sure David will correct me if I'm wrong. But there are lots of them now. And the idea is they're just a sort of template for a problem that, a sort of abstract problem that can arise in many different places. But if you understand what's driving, if you understand, the archetype really sort of extracts the essence of the problem into such a way that you can kind of see what then the solution is. Of course, what you have to do, because they're very abstract, you have to spot which one is the right right one for your situation. And of course, because it's such an abstract thing, then apply it. But if you do, then it's clear how to solve the issue. So the example I've got, which is especially, I don't know again if Russell is listening, we've had some email correspondence, Christine knows about this, about potholes. And the issue is that you have a problem and you have a quick fix for it. So what the quick fix does, so the S, for those of you who are not familiar with the SD notation, the S means as the problem systems increase, the fix increases. So the more problems you have, the more you need the fix. You do the fix, and then the opposite happens. The problems get less. So you've got what's called a balancing loop in SD. It alleviates the symptoms in the short term, but what happens is you have unintended consequences that happen in the slightly longer term, and those cause the problem symptoms to recur. So if you've got your potholes, your quick fix is to just fill them in with a bit of stuff. I was in B&Q yesterday, and I could see you could actually buy stuff now in B&Q to fix potholes. But that doesn't actually solve the problem. What would actually be the proper solution would be to re-tarmac the whole road, and then you wouldn't get more potholes appearing somewhere else. But the problem is that A, it's more expensive to do that, and also if there's a quick solution, then we tend to prefer that to something that's going to take longer because it's urgent, it's right in our faces. And so the things that we have to solve today always seem more urgent than tomorrow's. So having said that, there are some very large models in SD as well. This is quite a well-known one, a model of all the causes, basically. I don't think anybody could ever understand that. I think all it shows is that actually it's a really complex problem and involving so many different sectors that actually, there is no quick fix for solving the problem of obesity. There don't seem to be sort of equivalents to archetypes in discrete event, but this is a fairly famous example of a relatively simple discrete event model, which was basically to educate politicians to the fact that if you have 98% occupancy of hospital beds, then you're going to be in trouble. And that's caused by the fact that arrivals and lengths of stay are variable. I mean, we all know this. It's like, queuing theory 101. But there was this idea that a hospital that wasn't operating close to 100% occupancy was inefficient. And so what this model showed was that really once you start getting above about 90%, you're having problems. So the red ones are days on which you didn't have a bed, and the blue ones are the days on which you had at least one patient who couldn't be admitted. And it was actually influential on government policy about moving the target down from, in fact, sort of 85% is taken to be the safe. Of course, now we're up here somewhere, aren't we? But in theory, you shouldn't really get much above 85%. So, digital twins. How am I doing, Gavin, or whoever's chairing this? No idea. Okay.
Fine, don't worry, keep going.
I'm all right. I've probably got about another 15 minutes, maybe 10 minutes, maybe.
Super.
Anyway, I'm not going to spend ages on it. I mean, this is the sort of latest buzz thing. I was at the Winter Simulation Conference in December, and the tracks on digital twins are just, enormous now. It's like the latest thing. I have to say, I'm not totally prejudiced against them. I think the fact that you've got a computer model of a real system that has this sort of two-way communication with the real system and enables you to influence the real world version by receiving live data and then, or near live data, and then either solving an optimization or simulation, whatever method you use, is a really fantastic thing. I think that the key thing is how detailed do they have to be, but more than that, what purpose? It comes back to this idea of model purpose, which is one of my problems with them in healthcare. So this was a review that was done 2024 about the issues facing healthcare, and then, you know, the problems that you might have implementing them. I mean, of course, first and foremost, data, and there's a whole load of issues about governance and privacy and all that. If you have, you know, Internet of Things devices scanning and sensing people moving around in hospitals, just, you know, you can't imagine it really. But also the fact that you know, there's costs involved, and I think there's even though there's a lot of, you know, what looks like exponential growth in publications, whether they will ever actually be used in healthcare to that detailed extent, the jury's out. So I mean, I would question to begin with whether it's actually feasible to build a twin of a hospital. Because if you think, I mean, assuming that you can actually do it technically and you don't have any problems with privacy and the cost of installing all these sensors and cameras and everything that you might need to collect data, you're basically talking about a very, very large human activity system, if you like. It's not a production line. I mean, I know we simulation modelers like to build our models as if patients were moving around, but patients and staff are human beings, and whose behaviour is influenced by a whole load of factors that are not necessarily observable. And every event that happens in a hospital is the sort of end result of a whole load of factors that that relate to things that, again, are not necessarily observable. And so even if you had, you know, a vast database of past data that you could somehow put into a large language model and get it to kind of predict what would happen in this particular circumstance, you're talking about astronomically large number of different scenarios for even the most trivial things, you know, like, do I take this patient to the toilet now or do I leave it for 10 minutes? So I think you just try and imagine the computational effort that you would need in order to do that. And you'd have this problem, you know, that kind of arose in the previous talk about where you draw the boundaries. I mean, do you ignore everything? Do you just look at the hospital and ignore everything that goes on outside? Do you ignore ambulances? Do you ignore GPs or social care, nursing homes, etc.? And I think this is one of the, you know, the endless fascinations about working in healthcare, is that everything affects everything. And I know that's probably true in manufacturing and transportation and other things, but I think in healthcare it's particularly the case and particularly complicated. So I'm not convinced you could ever have a full twin of a whole hospital. Certainly a part of a hospital, or maybe a network of kind of units in across a region, for instance. I mean, if you look at the literature, there are people who claim to have built digital twins of hospitals. If you look at them closely, not all of them have received live data, even on a daily basis, let alone on a minute-by-minute basis. And a lot of them also look at specific parts of or specific bits of kit, which makes a bit more sense, I think. But I think that the crucial thing is, so it comes back to the fundamental idea why we're building models, which is to model a problem. And people that build digital twins tend to think, let's just build a model and then it can answer any question that could ever be thrown at it in the future. And I think you just don't know what sort of questions you might want your model to answer. If you did know, then you would build a much simpler model that answered that question. But if you didn't, then again, you might leave something out simply because of the enormous scale of the thing. So as far as I'm concerned, it just goes against this basic principle of look at the problem first and then think, what do I need to put in the model to answer that problem? So as I say, I think you can, if you have specific things then it makes really good sense to have a live model. But if you go down to the sort of detail of individual bits of medical equipment, then, you know, absolutely not. So we're nearly at the end, you'll be glad to hear. So my first lesson was about, say, the fact that this a project has many dimensions. And I think for this project, a lot of it was to do, a lot of the actual part of the modeling phase was going around talking to people, getting them to understand their system. And we just took this large piece of A0 paper with this map and just went round to about 30 different people in different parts of the system. And those conversations were really enlightening for them more than us, because they learned about their system through the fact that we were trying to actually model it. I mean, again, this is sort of received wisdom. We all know this, but actually observing it in practice is quite helpful. And we also built these very small models, I call them food for thought, kind of archetype type models, about why actually, to some extent, long waiting times in the emergency department are not a totally bad thing, because they discourage people from going. So if you know the waiting time is going to be 6 hours, you might try to find some other alternative, like in this case, go to a walk-in centre, or maybe wait till the following morning and go to your GP or go to the pharmacy. And the fact that if you do put in extra funding to create extra resources in the emergency department and bring waiting lists down, all that does is attract more patients, because they see in the paper that, you know, there are all these new staff. So you actually end up with not a very desirable situation. Yeah, that's the last one. And this again was about what level of detail is necessary. So this was one of, is Honora here? Was Honora was, Dave was, you were part of his team, weren't you? Or were you? I can't remember.
I was a student with him.
Oh, okay. All right. Yes, of course you were, when he did his master's. Yes, because he came back to do his PhD later, didn't he? Yeah, okay. But so his model was looking at basically Alzheimer's and how the top part here was a sort of aging chain, a standard thing in SD, where you weren't interested in individuals, you just wanted the population level. But once people had the onset of dementia, so this is not necessarily being diagnosed, but actually the onset of dementia, then they moved into the agent-based part of the model, and so the agents were created. And so that part was more complex, but the actual progression of disease was relatively straightforward again. So each of the separate parts were fairly simple on their own. It was the connection between them that was the complex bit. And so when you were looking at scenarios, to say, supposing you could, you could have an intervention that slowed down progression or delayed the onset, then what impact would that have at a population level? Then it was that was where the complexity was. The actual structure of the model was quite simple. So we could have made the whole thing an agent-based model and had hundreds of thousands of agents, but that wasn't necessary for this model. The third one, this is one for Stefan. This is a live project. Well, she's not fairly live. It's a handheld device that could be used to screen out patients needing to attend an eye clinic who, at the moment, they have this thing here called EDT, which I can't remember what it stands for, but it's some piece of, it's a bottleneck in the system, basically, because these patients have to, there's more patients arriving than they've got clinic slots to do this. But also a lot of patients don't actually need it. So the idea of the handheld device is that anybody, a nurse in a clinic could do this, and then that would, for those patients who don't need the EDT, they get treated somewhere else, and so that would bring the waiting list down. So the actual real world system is quite complicated. I mean, there's 4 different kinds of patients, and they have different needs for having this EDT thing, and different proportions of them need it. and the it's not clear. This piece of kit is not in current widespread clinical use, so they're not really sure how sensitive and specific it is, or how good it is at picking out positives and negatives. So basically, the model was looking at, would it be useful to use this thing under different assumptions about you know, how many patients are arriving, and also how accurate the test is. So it would have been quite tempting to try and model the whole thing and what happens to patients after they've gone through here and they've had their appointment, etc. But actually, what we were really interested in was showing, is it worth doing or not? And so you could just cut out a lot of that detail, and the answer is yes, it absolutely definitely is. Even if it's not particularly accurate, it's still better than not using it at all. Again, I think, well, we are currently trying to publish this model, but in an I journal rather than an OR journal, because I don't think we'd ever get it published in an OR journal. My fourth lesson is about kind of going against what I've said about simplicity, and the fact that there are times when you have to add in what is, you know, as the modeler is unnecessary, but if you don't add it in, your client or your stakeholder won't believe your model. So this example was from a project I did about 35 years ago, almost. I was doing my PhD, and it was for an automated port. And so you had these rail-mounted gantries that came along and then picked up these great containers and then put them onto lorries, and the lorries then drove off on the road. And so I didn't actually write the simulation. Somebody else had written the simulation. I just wrote the sort of graphical output to show the client. And when we took it along and showed it to them, and they said, yeah, it's great. But could you possibly make the railway lines where these guided vehicles went along have little lines on them, like hatching, like you would have on a child's map, just to show that they're different from the roads? And okay, if you insist, you're the client, the customer is always right. It was quite a lesson to me that actually that was totally unnecessary in terms of what the output looked like. I mean, it was obvious which these great gantry things were, but it was just something that you had to add in for them in order for them to like the model more. And so I think ideally, like in that situation, add it into something that you don't actually need to do a lot of coding for, or things that don't actually do anything in the model, but you just put them there because it'll keep the client happy. But even if you can't, you're forced to add something in, otherwise they won't listen to you or meet with you again or give you data. It's still better to have a model that is too detailed, but it gets used, rather than one that doesn't. And so I think this is almost finally. There's this saying, once a nurse, always a nurse. And I think it's really true, because I think even today, I mean, it's a long time since I've been on a hospital ward other than visiting or as a patient. But I think there's times when I would mention it and there's times when I wouldn't, because I know now I'm really out of date. But I think I never forget that actually what I'm building models for is patients. In the end, they're the ones that really this is all it's about. And I think it's working in healthcare, you have to be incredibly patient, and patient in the sense of being willing to wait rather than being a patient. I think there's you do a lot of selling to convince people who don't think that modeling can help them. But then having actually got over that barrier, then you have to manage down their expectations that you're not going to be able to solve every problem that they can come up with. And also the really frustrating thing in healthcare is that people in the NHS move around such a lot, and you spend ages building a good relationship with the person that really gets it, and then they move on. So this picture is not me, but it's what I did look like. I Googled 1970s nurses, and that's what I came up with. And I did have a cloak like that. So all in all, I've had an absolutely fantastic career. So I think, Yeah, this is it. I did want to include this paper, especially for Chris. It's the only paper I've actually written with Chris, and it's still my most highly cited paper. I looked it up this morning, 634 citations. The next one is a healthcare paper with Paul Harper, which I think might have been a Wright paper actually, Terry. That 2009, I think it was that one. But anyway, I say just thank you to the OR Society for giving me the Beale medal, which I have to say was quite a shock. But thank you all for coming. And yeah, that's it.
I don't want to steal your thunder, Sally, but this is fresh from the field.
Oh, wow.
And a little card. So I will, first of all, I think it was an amazing presentation that I think some wise lessons can be learned also for other fields in optimization, for example. I think there are several nuggets in here that I can teach my students. And I will try to keep it short, given your presentation. You know, short is good sometimes, small is good, and not too complicated. So therefore, you know, my name is Patrick Volens, and I'm the director of the Center for Operational Research, Management Sciences and Information Systems, also known as COMSIS. And on behalf of COMSIS, you know, all the members of COMSIS, we have 60 plus people, academics, 50 plus academics, we have PhD students, we have people in the management schools, which is now called Southampton Business School, of course. And we have mathematical sciences in here and beyond. We have some people in healthcare and in engineering. And we are one happy community in COMSIS and have always embraced also Sally's input here. She has actually established healthcare in COMSIS, I think. And of course, as you witnessed beyond across the world, she has gained a good reputation. So on behalf of COMSIS and all the distinguished guests that are here and the people that are listening, we want to congratulate you with this prize that has been bestowed upon you by such a wise decision of the Operational Research Society. So congratulations.
Hello, everyone. Let me stop sharing.
There are 29 things in the chat. Someone needs to say something.
Oh,
Right, I think we've got plenty of time still for questions. Got a couple on the Q&A. Are there any from the room to kick us off?
oh, Mark.
Do you want me to stand in the microphone?
Are you able to hear? Did you hear that?
We can hear Mark, yeah.
Oh, brilliant.
So the question is that there's obviously a need to publish papers, and you and many of us are all saying that there's a judgment to make between complex models and simple models. Surely there's a paper on how you actually do that. You know, the whole issue of, I mean, it's the most important skill of an OR person, isn't it? Deciding what to include in the model and what not to include. And many times it's wrong. So there's a huge wealth of publications to be had there.
I mean, I completely agree, but I mean, I think this idea about whether it's an art or a science comes into that, because I think it's so difficult. I think that is the really hardest thing as a modeler, to know what to leave out.
Therefore, you should be publishing on it.
Yeah.
Or running a training course.
I would love to have a go, but I think it's really difficult.
Just related to that, one of the Q&A questions is how could we set up a journal of case studies for publication of maybe unsuccessful projects? it would be a great resource.
I mean, we have tried to do that. I think it's quite difficult because you're up against the whole sort of academic career structure. And people would, if there was such a journal, people would say, oh, well, you know, that's only a ABS 1-star or whatever. And nobody would submit papers to it.
Perhaps it's a special issue of Impact magazine.
Yeah.
No, it should be a strand in JAWS. It should be
Yeah.
an area that JAWS accepts. That's not going new journal. We've got a good journal. It needs to expand its scope a little bit, or we need to have the courage to write those articles.
I think that's a big part of it, is
My
people don't submit them.
failure in client X, right? We could all write those papers.
One from Sanya here.
Yes, I will use my role as the president to ask actually 2 questions, Sally. First, following on the discussion about modeling. Generally, if you want to publish in a journal, your model should be general, applicable to a variety of healthcare organizations. But I also think if you want your model to be applicable to a particular organization, you want a tailored solution, tailored model that will address particular needs of that organization. What is your view on that, or advice on that?
I mean, I think a lot of people have tried to build generic models that can be applied more widely than just one area. I mean, I'm thinking particularly in simulation, but I think, I mean, I guess a lot of what I've said applies specifically to simulation rather than a more mathematical approach where it's clearly more, you know, more naturally applied to other areas. But I mean, I think you know, I mean, we're kind of taught that you have to work closely with your stakeholders and that you involve them in the process. You know, if you look at all the work on success factors, they all say that, you know, it's really important to, you know, to get trust and buy-in and the rest of it. I mean, I think there's definitely a place for case studies. I mean, you know, I don't think you can dismiss the idea of, you know, a model that only works in one place as not being publishable, because it's still interesting and people can still learn things, even if you're describing a case study application that is unique to that one place. I mean, it's kind of the holy grail, isn't it, to have a model that you can apply, you know, you can take from one place. But I mean, I think it's a challenge because people will always say that, you know, I can't apply this model to us because we're different, or you know, our systems are different, and which is an argument for keeping things simpler so that there is less opportunity for people to say that. You know, I think it's a challenge to, I mean, you know, lots of people have tried to build simulation models for emergency departments that can be applied in more than one place, and generally they've failed.
I think the same applies to optimization approaches.
Probably.
Usually, if you want that to be applicable, it has to address all the particular needs of a healthcare organization. Another view, I fully agree with your comment. We as a community should make more effort to make our models implemented in healthcare organization. But there is one big problem. We need ethical approvals. And I can say that for that, you really need to be, I'm serious, mentally strong to have all the paperwork done. Often in the same form, you have the same question on different pages. Then it makes your work more exposed to different healthcare organizations, but it is really a tiring work. It's not the place now to complain, but that is a real issue if you want to work with healthcare with, let's say, NHS.
Yeah, that's one of the many challenges. Yeah.
Thank you for your excellent talk, I think. Okay, next one up from the Q&A from Amanda Whitfield. Is there any particular NHS problem that you would really like to develop a model to solve?
Right now, it would be the issue of integrating health and social care systems. I mean, there's a little bit, I think, that Lizzie alluded to about the challenges of data. You know, it's bad enough in the NHS, but the social care system is so diverse that, you know, there isn't one single organisation, it's multiple organisations, public and private, and I think it's such a challenging area. But I do think that's one of the key problems at the moment that's causing such issues with the NHS. And then the knock-on problems that creates as well. I just think if we could get a truly integrated model that looked at how to tackle this issue. I don't forget it's something like 40% of patients are in hospital that don't need to be, but they can't be there, they can't be moved out because there's nowhere for them to go. So I think, you know, as a bit of common sense would suggest that actually OR should be able to, you know, to apply some logic to that problem.
Yeah, absolutely. Another one from Ruth. On the first part of your talk, do you think academics working in different application areas would have a different story to tell with respect to success? Is it a healthcare issue or an academic research issue? And are there any countries which might exemplify a less dysfunctional relationship?
So I think healthcare is slightly worse. I mean, I know Stuart Robinson and Twila Taku did a study about healthcare, and I know they interviewed people that worked in many different sectors, and they did find that healthcare was slightly different. But I went to the German OR Society conference in 2023, and the keynote speaker was the director of port operations at Hamburg, and he started his talk by a slide like mine with hundreds of academic papers on sort of port logistics. And he said, basically he was saying, this is an area with an enormous academic literature, all sorts of, you know, probably not quite as big as healthcare, but possibly similar. And yet, do they use any of them? You know, I'll give you 3 guesses. So it was quite, I was quite surprised actually, because I did always think healthcare was worse than anywhere else. But I think it is possibly an OR problem that we're sort of forced into developing these incredibly complicated models that really just are only useful for getting us promoted and not actually making a difference, sadly.
I think this is pretty much the last one that we haven't already covered. This one comes from a new OR researcher in an academic setting. Would you advise junior researchers to prioritize learning a specific simulation method and use it as our primary tool, or should we be learning multiple simulation methods? He or she says, academic setting probably requires the former to be an expert, but the latter is probably more useful. What do you think?
So I would definitely think learn all of them, because problems are complex. And I think if you're trying to build a model as simple as possible, it's not always possible to do that just using one method. And so I mean, hybrid simulation is now an area. So, I mean, that kind of addresses the problem of not being an expert in system dynamics. Or I think our students are now learning all 3, and they're also not learning a particular SD or DS software. They're using any logic. Sorry, Mark. So hopefully they will be equally adept in all of them. I mean, I think probably it's not just healthcare. I think probably most real world problems are like this, that they have different aspects, and that if you have, you know, if you limit yourself to one particular method, then you're actually not necessarily using the right tool for the job. So I would definitely advise anyone to to learn all three and try and be agnostic between them, although you probably might naturally move towards one or the other, but
Okay, great. Thank you very much, Sally. That's wonderful and a great talk, as you'll no doubt see when you read through the comments that have been raised online, and you'll hear from your colleagues there in Southampton. In terms of our online section, I think we've reached the end of our time. So we'd like to thank both you and Lizzie for sharing your thoughts on these two great topics with us. And we hope you enjoy the rest of your time this afternoon with your colleagues there in Southampton.
brilliant. Thanks very much, and goodbye from us.
Thanks, folks.